afternoon, everyone. I'm Dr. McKinney King, Interim Vice Chancellor and Director for UMKC's Division of Diversity and Inclusion. On behalf of all of UMKC, I want to welcome you to another installment of UMKC's Critical Conversations. Racism is embedded in the fabric of our society. The movement for Black lives and tragic murder of Black and Brown people sparked a global movement in 2020 that highlights the dysfunction of racism. Every person is impacted by racism, and we need to address this topic head on, even though we have historically been discouraged from doing so. The goal of these discussions is to enlighten, educate, and explore the causes and potential cures for racism. Today's discussion is the 10th installment in our series, centering the topic of COVID vaccinations and misinformation in communities of color. At the conclusion of this conversation, we want you to take this information with you and integrate it into your commitment for racial justice in the future. Also, if you need closed captions during the program, please click the closed caption button at the bottom of your screen. And now I will turn this over to our moderator, our own Gary O'Bannon, Executive in Residence at the Henry W. Block School of Management. Gary?
Thank you, Dr. King, and welcome everyone. It is a pleasure once again to serve as your co-moderator for this event. Shortly, you'll be formally introduced to our panel of subject matter experts because that's who you came here for. But first, let me begin by saying hello to my co-moderator, Angela Wankwo, and allow her to introduce herself. Listen closely though, because if you're lucky, she may be your doctor one day soon. Good afternoon, Angela.
Good afternoon, Gary. Thank you so much. Good afternoon, everyone. Thank you for joining us so much for this panel. My name is Angela Wankwo, and I'm a final year medical student at the University of Missouri at Kansas City School of Medicine. I'm really privileged to be a part of this conversation and great to know that UMKC is taking strides.
All right, Angela, I'm honored to have you join us. And I thank Dr. King and others for making that happen. Our future is bright. Look at the people we're cranking out here at this university. Let's now move to self-introductions of our panel. You saw their names and titles on our event announcement, but let's get to know them just a little bit better. We'll begin first with our own Dr. Berkeley Patton, followed by Dr. Olarte, Ms. Thomason, and then Mr. Thompson. Dr. Berkeley Patton, why don't you start us off?
Hello, everyone, and thanks so much for this opportunity to be a part of this panel. I'm Jeanette Berkeley Patton. I am a professor at UMKC in the School of Medicine in the Department of Biomedical Health and Health Informatics. And my research primarily focuses on health disparities, particularly in my role as the director of UMKC's Health Equity Institute.
Hi, good afternoon. Thank you for the invitation. I am Lisette Olarte. I'm a pediatric infectious diseases doctor at Children's Mercy Hospital, and I'm an assistant professor at UMKC School of Medicine. I'm also a co-chair of the Latino Employee Resource Group and co-founder of the Latinos in Medicine group here at Children's Mercy.
Good afternoon, everyone. I'm Kiana Thomason, President and CEO of Health Forward Foundation. Very pleased and honored to be with you all today. Health Forward Foundation is a philanthropic partner in community health. We serve the Kansas City region, both urban, suburban, and rural communities in our bi-state area, which includes all of Kansas City Metro, and in Missouri also includes Cass, Lafayette, and Jackson counties. And in Kansas, Johnson, Wyandotte, and Allen counties. We provide about $23 million on average in grant making a year, as well as a lot of leadership and advocacy.
Good afternoon. I'm Frank Thompson. I'm the interim director for the Kansas City, Missouri Health Department. I've been with the department for 22 and a half years in a variety of roles. And it's been interesting to take on this challenge as director in the time of dealing with a global pandemic. But we are a resilient department that strives to serve the citizens of Kansas City, Missouri. And looking forward to this discussion. And I too was honored when the invitation came for me to be part of this distinguished panel.
And a distinguished panel indeed. Thank you each for your service to the community. We really do appreciate it. All right, so for the first 45, 50 minutes or so, Angela and I will have a series of questions for our panelists to be followed by about 30 minutes of questions from you, our guests this afternoon. You can engage with this panel by submitting a question into the Q&A function on your screen. Some of you have already done that, so thank you for that. And I'll apologize in advance because time is always very short when we have these critical conversations, but we promise to try to get to as many of them as possible. If it's possible, the panel can also try to answer some of the questions that you may not hear publicly, but you will be able to see our responses, or their responses rather, in the Q&A box. So we'll certainly do our best. And thank you again for being here. All right, so we're going to go ahead and get started. I'll ask roughly 4 or 5 questions, and then I'll turn it over to Angela, and then we'll transition into the Q&A from the community. So the first question goes to Dr. Arlate. African Americans and other underserved communities as well have a lasting and lingering distrust of healthcare providers as well, and of the systems and the institutions that they have supported. So we don't want this to be dominated, we don't want this to be the dominant discussion of our panel today, but it might be helpful to at least frame the history for our listeners as to how we got to this level of distrust, which hopefully is lessening. Dr. Olarte?
Yes, absolutely. Well, mistrust in the healthcare system stems from historical events related to wrongdoings in medicine, of course, but also from other discriminatory practices that have impacted communities of color and that may continue to this day. The most known example of unethical experimentation in healthcare is the Tuskegee syphilis study, which lasted 40 years. It ended in the 70s, so not that long ago. And for the ones that are not familiar with this study targeted the Black men. It included around like 600 Black men with and without syphilis. And this was not conducted by any random researcher. It was conducted by the U.S. Public Health Service and the Tuskegee Institute to study the natural course of the infection of syphilis. But the participants were not informed of the real purpose of the study, and which is more concerning is that once penicillin became the standard of care, the participants were not offered the treatment. And if you are not aware, syphilis can cause permanent neurological and cardiac damage and damage to other organs, and can be potentially life-threatening. So, I mean, obviously this has deeply impacted the relationship between the Black community and the healthcare system. This just adds to the historical trauma of the slave trade and racial segregation. And even today, we continue to have false beliefs about Black patients in medicine. Just one example is the misbelief that Black patients have like a higher pain tolerance, and therefore they are consistently undertreated for pain. That's just one example. If we talk about the experience of Native American communities, which, by the way, November is Native American Heritage Month, so we should take this as an opportunity to learn, educate ourselves, and also make these communities visible. So if we start from the very beginning, they were forcefully removed from their homelands. Their native languages and religious practices were banned. Children were forcibly removed from their families and sent to boarding schools. More recently, more than 3,000 involuntary sterilizations were performed on Native American women. And to all this, we add the current indifference from the society in general to the crisis of missing and murdered Native American women and girls. There's also a recent, relatively recent case of unethical medical research that affected a Native American community, which I don't know if all of you know about this, but it's known as the have a supply diabetes project. And this is a tribe in Arizona that was facing really high rates of diabetes in the early 90s. And well, so they agreed to be part of a study to try to figure this out with a professor that they trusted from the Arizona State University. And it was the first time that they were providing blood samples, because in their culture, blood had a significant cultural and spiritual worth to them. And to make a really long story short, their blood samples were used without their consent or knowledge for other studies that explore genetic causes for schizophrenia, inbreeding, and even something not related to medicine or health, like population migration theories. And of course, this impacted their trust in the healthcare system and prevent them from getting the care they needed, because they just didn't trust the system anymore. Other tribes heard of this, and of course, that created other problems. And I mentioned that the issues with reproductive rights that Native American women face, but other women of color have faced similar problems. Black women and Latino women also were involuntarily sterilized in California in the early 900s, and something similar happened also to women in Puerto Rico. Recently, we had allegations that are currently being investigated, also of involuntary hysterectomies, that is the removal of the uterus performed on immigrant women at a detention facility. So all this, of course, impacts how these communities perceive institutions in general, that includes the healthcare system, and also to mention the experience of the Latino community. There's been an anti-Latino sentiment for decades in the country. It's true that many Latinos are immigrants, or their families are immigrants, but are many that, especially on the West, that their families have been in that land for centuries. And you've heard this before, they did not cross any borders, the borders crossed them. So despite of that, they continue to face discrimination and make feel that they don't belong here. And at some point, Latinos were also segregated. They were not allowed into restaurants or other public settings, and even schools. We don't have over segregation to Latinos anymore, but discrimination continues to happen and is impacting mental health, physical health, and the access to care.
Absolutely. And even still today, African-American women are still 3 times more likely to die from pregnancy than white women. All right, so given all of this, what are some of the best practices, if there are some out there, for things like restorative justice, partnerships with trusted messengers, and any innovative and culturally sensitive ways to share information about the COVID-19 virus and just vaccines in general, since the trust has certainly extended to this pandemic? Ms. Thomason?
Sure, thank you, Gary, and I'm very appreciative of Dr. Olarte for her very thorough and inclusive representation of the injustices that we have seen both historically and in our contemporary times. I think that sets the table well for the conversation of restorative justice. And I think everything that you mentioned, to include partnerships with trusted messengers and innovative cultural methods and channels, can all be considered restorative practices. One thing that I'd like to hone in on first is the opportunity for our community health ecosystem, which includes payers, healthcare payers, providers, including hospitals, health systems, public health entities, and our social sector partners, to begin to track race, ethnicity, and language data in a uniform, standardized, and systemic way that allows us to use these data as quality improvement methods and processes, just like we would apply to the practices around improving chronic condition management or improving any type of root cause adverse factors in a health system. it's time for us to begin to look at the disparate outcomes that result in health injustices. And it's time for our states, for Missouri and Kansas, and our federal government to commission and require the use of race, ethnicity, and language data as quality improvement channels so that we can ensure that we have the full picture. We cannot change what we cannot measure, and we yet only know half the story, even in COVID-19, as only about 40% of that story is told because of lack of race, ethnicity, and language data. So that's the first thing that I'll call out as foundational to restorative justice's best practices. The other thing that I'll mention is with respect to partnerships with trusted messengers. So we've seen best and promising practices here locally as well as nationally, where communities are centering the people and the channels that carry proximity to communities, who carry the trust of communities, like our faith-based communities, which Dr. Berkeley Patton has worked with for many, many years and has researched with respect to best and promising practices. Beyond, of course, physicians and care providers that look like us, we cannot undervalue the influence that individuals such as barbers and beauticians, pastors, and all of these people who hold very influential roles in our community have on the thinking and the shaping of thoughts, beliefs, and practices in our environments. I'd also like to call out, and within that realm, I'll mention that Health Forward partnered with Reach Healthcare Foundation and Wyandotte Foundation to offer many grants to a host of nonprofit as well as grassroots organizations that don't have nonprofit status to be the trusted messengers, partnering with public health community entities like the Kansas City, Missouri Health Department to carry fact-based information to the communities, to the schools, to the community centers, to the churches where people are naturally gathering. We can't also forget the importance of media and of course social media, but we can't leave out our seniors who are still looking at publications like The Call, Dos Mundos, The Globe, and Our Health Matters, a publication that has a multifaceted stakeholder audience and readership in our community. So it's important to leverage the voice and message and amplify such of people and channels that carry the trust.
You know, you bring up a good point. So maybe this question is best for Health Director, Mr. Frank Thompson. So she had just mentioned, you know, some of the other traditional outlet, you know, barbers, pastors, community activists could be another. I mean, people that the community see 52 weeks out of the year. Are public health agencies walking that talk by acting as partners with the community as opposed to just focusing on vaccine distribution efforts in these underserved communities?
Thank you for that question. I think, you know, for me and my role, I think part of walking the talk is also recognizing that this response is a community-wide and regional effort. And for us as a department, recognizing that there are different roles for different partners in that work. And in order for us to be successful, like any team, everyone has to be able to accept and succeed in their role. So although we work with faith communities across a number of issues, whether it be immunizations or a number of other things, one of the things that we have recognized in this pandemic is the UMKC group that Dr. Berkeley Patton heads. They have access to a faith network that really targets the populations that are most underserved in terms of our vaccine access and distribution, have been the hardest hit in terms of cases. So understanding that they have that ability to reach that population and supporting that. So, you know, in addition to their vaccination efforts, we also partner with them on an NIH grant to provide testing in churches and serving that same population. And also just in going after federal funding and coordinating applications with them around funding they were also seeking to do testing. So I think, yes, there's a need for health departments to engage more and be more in touch with what's going on in the community. But there's also a need for us to recognize that the health department coming in and saying, we're here from the health department, we're here to save you, is not always the best message. It's not going to be well received in all circumstances. And, you know, that's one of the things I'm excited about with the two most recent federal grants that we've received. And it's allowing us to really get out and work with some of these community organizations and support not only their work around COVID awareness, but also their work around developing their own organization capacity in a significant way and putting some significant dollars behind that.
Mm-hmm. Very well said, and thank you for those points. You know, it seems obvious that if you don't have a trusted source in the medical community, say your personal doctor that you've established a relationship with, then you fall more prone and subject to being pulled into the disinformation loop that we've seen since this pandemic began. For example, if your parents don't have a regular checkup schedule, they may only take their child to the doctor and when they're sick. And even then they may go to the ERs or go to urgent cares, not a family physician where personal connections are made. Are we not going to solve our lack of healthcare problems anytime soon if this pattern continues? Or is it, you know, as simple as just saying that we continue to need to educate folks and that's the answer? Dr. Berkeley-Patton?
Well, I'd like to go back to some of the things that Kiana had began to touch on.
Okay.
We know that our medical system is really set up to treat sick people. And really, when you're talking about improving health, you really have to talk about relationships. And so we really need to begin to think about how do we restructure our medical systems. And COVID is really a good, I guess, litmus test on how we can do this. More so what we saw with COVID than ever before, we saw health services getting pushed out into the communities where people live, where they get their hair cut, where they grocery shop, where they worship. And these models of delivering healthcare services really need to be tapped into much more deeply. And we need to figure out how can we combine these structures for what happens in the medical setting with what happens in the community where people, you know, again, live and worship and work. And so this is a great opportunity to be able to do that. And there are a couple of best practices that I'd like to kind of highlight that really have been taking place for a couple of decades, but even more so over the last 10 years. And one of those is really having good, strong policy in place to provide services through community health workers. Study after study shows that when you can find people from the community and equip them with the knowledge and the skills that they need to make those connections with people from the communities that they live in, people who look like them, people who talk like them, that others will be more likely to engage with the medical care system. I mean, we know for many people of color, when they come to the emergency room, like that's their medical home, or when there's some type of emergency that takes place, the mindset is get in and get out, because of many of the things that Dr. Olarte referred to, and people's current experiences and just really not having a good experience in the medical system. And so community health workers are an incredible way to bridge developing those relationships and linking people to medical care. The other thing that I'd like to propose, and something that we're learning in one of our projects, our Healthy KC Eastside, which is providing COVID-19 vaccinations and other health screening services through neighborhood associations, with businesses, with youth organizations, and with faith-based organizations, is that when you can equip lay people from the community with, they don't have to be medical experts. They just need to get about 3 good, strong points going, and they can talk with their peers, their family members, their church members, their customers, their neighbors about things like COVID vaccinations or other health disparities that are impacting our community, we have found that time and time again, they can be just as influential as health professionals in getting people the services they need and getting them linked to those services and encouraging them to show up, and then being there when they actually show up, particularly in getting vaccinated, to say you can do this. And I think those two models have just incredible promise in getting people not only into medical care, but finding them a medical home and keeping them there.
Ms. Thomason, anything to add?
Dr. Patton did an exceptional job of talking about the invaluable role of community health workers. I just want to kind of amplify where that's working well in our communities. Many of our federally qualified health centers, specifically KC Care, is really using or leveraging, partnering with community health workers in a very dynamic way. We also see in our Hispanic and Latino communities, we see the partnership with Promotoras, which El Centro in Wyandotte County has really began to leverage these individuals as trusted messengers. They live among the community, they speak Spanish, they understand the fears that are quite nuanced from other communities of color, as Dr. Olarte mentioned. At Uzazi Village, we see the partnership with Sister Doulas, who have been working for many, many years to reduce the health injustices that we see around maternal and infant mortality among Black and Brown communities. And they're partnering with these families and with these women to not only reduce the mortality, but also to educate around the importance of vaccination. And then in our mental health and substance abuse communities, treatment partners, we see use of peer specialists that are trauma informed and oftentimes can relate to the individuals who are receiving behavioral health and substance use disorder support and can act in a very trusted way and educate with respect to vaccinations. And so just wanted to call out and amplify where we see this happening and working very well in our communities and who's leading that work.
I see Director Thompson getting ready to jump out of his seat. Frank, anything to add?
Well, and just wanted to say on that, as I'm sure some of the folks on this program today listening are leaders, like many of the panelists, and just the need to be open and to be willing to listen to what's coming from the community. And just to give an example of that, one of our health commissioners approached me a couple of months ago about attending a meeting to talk about how youth could be involved in helping to educate around COVID. And went to that meeting, liked what I heard. They did a pilot project. I actually helped train the youth as part of that pilot project. And the results that they were able to get, volunteer, just youth who were interested in helping to spread the word among their friends, was good enough that we are now funding that as an ongoing COVID awareness and outreach project. But if I had ignored that request to attend the meeting, we would have missed out on that opportunity.
Thank you for that response, Dr. Thompson. Dr. Olarte, we just wanted to address the information that's been going on with the COVID pandemic. Some would describe this as an infodemic because there's so much information going around. So infodemics can be defined as an overabundance of information, good and bad, but perhaps they are more critical than the quantity of information because it's fast moving, it changes fast, and that's what makes the information hard to understand. This has produced a quick spread of misinformation online, promoting a false narrative around vaccine hesitancy. I'm sure some of us have seen these things on social media, lots of dialogue and engagements about this topic. And some of it is authored by members of the health community as well. So what are some of the leading false narratives about the COVID-19 vaccine that are targeting communities of color?
Yes, so the false narratives have changed so much during the whole pandemic. At the beginning when the vaccine was not ready yet or available. Some of the false narratives, I mean, were the same as anybody else's, right? But there was some that were very specific for some communities, even related to being tested for COVID. And this was a significant issue for some undocumented immigrants because of the misconception that, you know, they will get there if they go to a healthcare facility or someplace to get tested, their information would be shared with the government. And so there were many of them that were not seeking care, not getting tested just because of that. Something similar happened when the vaccine became available, and the amount of personal information that you have to enter into the forms to request vaccine appointment was also a barrier for some communities. We've all heard about, you know, how the vaccine is introducing a chip that can track you. And so that's of course not true, but, you know, for some of these undocumented immigrants, that was a significant concern. And that was another thing that prevented them to access care. And of course, the other big misconception that's still an issue today is the concern of fertility. And, you know, like this may be for some communities deeply rooted in what's happened in terms of the reproductive rights of women of color. But yeah, I mean, it's not true. We just need to understand where these misconceptions and concerns are coming from. But in my opinion, the leading false narrative is that the communities of color don't want to get the vaccine. I think early on when the vaccine was available, that was leading, you know, that was the main, it was everywhere in the media. Oh, communities of color are hesitant about the vaccine. That just put another label on these communities, right? Like, oh, they are uneducated, don't believe in science, the vaccine is free and they are refusing them. At some point, communities of color were being blamed because the pandemic was ongoing because they were not getting the vaccine. And this is when we think before the pandemic, historically, these communities have been very receptive to vaccines. So I think we failed them again early on because many of these communities were not necessarily more hesitant than anybody else about a new vaccine, but they were maybe more hesitant about the system that was providing the vaccine, because these institutions have failed them many times before. And we also fail early on to discuss inequities in vaccine distribution and lack of access to care as important factors related to these lower vaccination rates in communities of color. So today, that vaccine gap that we saw between the white population and the Black community or the Latino community is not as wide. There's been several studies showing that in many states, the vaccination rates of the Hispanic or Latino community has equal the white population in that specific state or even surpass them a little. For the Black community, that vaccination gap has also decreased, but it still persists in some states. And so I think to me, that has been the leading false narrative. There's been surveys even in the Native American community where they included 1,500 members of different tribes. And they, like 75% of them responded that they wanted the vaccine. And when they asked them what was the main motivation, they responded that they wanted to protect their community, and not only protect their community, but to protect their culture. You know, they've been highly impacted by COVID early on in the pandemic, and they've lost so many members of their tribes, and with that, many tribes elders. And on top of losing a loved one, with the loss of their elders, they felt that they were losing that connection to their culture, their community, their language. So, they had this sense of protecting their communities. Most recently, we have the example from Puerto Rico that they had their vaccination rates at that time, where this was published recently, was higher than any state in the United States. So again, showing that these misconceptions about communities of color, it was not necessarily hesitance about the vaccine itself, but the systems around it. In just an example from a Kaiser Permanente study or survey, they recently asked Hispanic adults that haven't been vaccinated yet, what was the major concern? And of course, side effects was a concern, but immediately after that, like 65% of them, their main concern was that they may need to miss work more than one day because of the side effects. And I have actually heard that from some of my families, the patients that I see. And so we may not think about those things. They were not really concerned about the vaccine itself, but everything else that would come with that, or that they would need to pay out of pocket. Even though we know it's free, this is something that we had to reinforce every time we go and talk to the community, that it's free, that nobody can deny them the vaccine, even if they don't have a social security number or they don't have insurance. That has been part of the information that they haven't have. And so, so more than the vaccine itself, it was everything else that came with that.
Thank you so much, Dr. Olarte. That was a great breakdown of all the other issues that affect the vaccine and potential described hesitancy that were going on in communities. Mr. Thompson, I know the health department is very relative to this topic, so I'd like to pass it to you and see what you'd like to add on this.
Well, I just wanted to make one quick point. Dr. Olarte started out with an explanation of the Tuskegee syphilis study. And I think it's important to note that that study started out as a study to demonstrate whether or not African-American men actually wanted to be treated for syphilis, because the common opinion in the medical community at that time was that Black men did not want to be treated for their syphilis. So it's a very interesting parallel almost 100 years later that demonstrates how deeply embedded the racism and bias is within our medical care system.
That's a good point as well. It's amazing to think about how these things are so deeply rooted in the system that they keep repeating themselves again and again. Dr. Berkeley-Patton, would you like to add to this as well?
I just have a really quick comment from what we're learning so far from our Healthy KC Eastside project with vaccinations that are primarily happening in some of the most socially vulnerable communities in Kansas City and in many zip codes that are primarily African American. And what we have found is that for people who are getting vaccinated, that many of them are not, just as Dr. Olarte had mentioned, and are not vaccine hesitant, but I would more so say vaccine slow. It's not that they've said no, it's a matter of, for many of them, that they just could not find the time or an accessible location to get vaccinated. And so many of them have said that, wow, this is so great that this is happening in a location and at a time, a Saturday afternoon, a Sunday afternoon, a Wednesday evening, where I didn't have to take out from work and I could actually come and I don't have to get a babysitter and the kids can come. And so time and time again, that's what we've seen, is that convenience and accessibility can make all the difference in the world here, and people making a decision to get vaccinated. The other thing that I'd like to comment on, similar to some of the data that she shared, what we have found is that the top 2 reasons why people are saying they're getting vaccinated, one is because of their family. They're concerned about the health and the welfare of their family. And secondly, because they're concerned about their community, that they sincerely believe that getting vaccinated will contribute to the overall health of their community. And so I just wanted to highlight that we're seeing that same type of response here in Kansas City.
I have a follow-up for Dr. Olarte and maybe others. We have talked about the inequities, both historically and those that still reside today in the healthcare industry. Almost all discussions online, on media, when they talk about vaccine hesitancy, always refer to this distrust and the rationale behind it, which is valid. But does continuing to put that out front in each discussion only serve to entrench that mistrust? Because people are being reminded about the inequities, and so they're going, hey, that's right, and then that is also contributing to them continuing to mistrust the medical community as it relates to the vaccine.
Yeah, I mean, I think in general with anything related to healthcare, I think first we need to understand the community that we're serving. That's a huge issue everywhere. We're trying to put everybody fits in the same box, and not every community is the same. And I think that's very important for all the communities of color. The Latino community, not every Latino community is the same. Not their needs are not the same. You have the spectrum of immigrant families that may speak Spanish only, or be bilingual, or be undocumented, or they may live in a household with mixed immigration status, or they may come from different cultures, based on their different nationalities from Latin America. They are all different in their practices, but when we just say, oh, this would work for the Latino community, and we don't recognize the differences among them, that also impacts the care that they receive. And the same for the Black community and the Native American community. They are all not monolithic communities. So, but I do think that addressing the issues of the past, it's important though, because if we don't mention them, because one of the issues is also the communities feel that we're not transparent. Like when something wrong happens, we'll cover it up. Nobody will be responsible. Like nothing happened, because it's happening to communities of color. So if we educate ourselves, we understand the community that we're serving, and we address specific issues that affected them, and we are open about them, and just recognize that that there may be a historical trauma in that specific community. I think just addressing them, it would create a connection. It would send a message to the community that you took the time to understand them, and that you are addressing their concerns. You're validating them first, and then you want to do better. I know that when we repeat this over and over again, it may put that in their minds more too, but it may also put that information in other people's minds that have no idea, or they forgot already. And it may be different when they interact with these communities. There will be a reminder to them as well that, okay, this happened. Maybe the women are so concerned about fertility because they grew up listening to a family member that was, victim of one of these forced sterilizations. Who knows? It may just open also dialogue.
Yeah, well, and again, and my point, just to clarify, is not to eliminate the education piece. Maybe it's just one more of placement, because it's always out of the box. And being the cynical person I am, sometimes I'm wondering whether certain media groups, that's by design, because they put it out front, as opposed to putting the information that is valid about the efficacy of the vaccine, et cetera, and the availability of the vaccine. Sure, don't ignore it ever, but mine is more of placement, and might be a very good question also for Health Director Thompson. Frank?
Yes, I just wanted to jump in on that. I think, one of the things I've been learning over the past few months is that it's really important to lead with empathy as we're trying to deal with this issue of individuals and groups that, for whatever reason, are not getting vaccinated. And it's been a hard lesson for me over that time. But I think part of that is acknowledging that pain that is there. And as Dr. Olarte said, once you do that, that creates that connection that then allows you to begin that conversation of, I understand where you're coming from. I'm not carrying on in that line or in that tradition. And then just one last thing about that, I've been using that a lot in my talks with community groups, because for me, it's in particular for the Tuskegee syphilis study, the real travesty of that was the denial of care for those men once there was a treatment available. And so when people use that as an excuse for not seeking care, my point is always, you are doing to yourself exactly what those researchers did to those men. You are denying yourself access to care. So don't let that study be the reason you're not accessing care. If there are other personal reasons or more, family-related experiences, let's talk about that. But don't use that historical injustice as your sole reason for not accessing care.
Yeah, and from a physician's point of view or from a community-facing point of view, I think that acknowledgement and that empathy out of the box certainly is critical. So maybe mine is still more the media messages using that as the lead off, which to me strikes me just as a manipulation, because what they can't say is don't get the vaccine. But if they keep leading with the distrust and you shouldn't take the vaccine because look at what they did in the past, some of that appears to be bordering on manipulation, because I think someone coming from the media 20 years ago, not to lead stories that way. I mean, you lead with the reasons why you need to get vaccinated in order to protect yourself, in order to protect your family, protect your community. But when you constantly lead with the distrust factor, I think that there's a message that's trying to be sent there. So from a personal point of view, totally get it. But from the media, how has the media, in your opinions, if you have one, how have they contributed to the hesitancy, if at all? Frank, I'm going to go back to you, just from the healthcare community facing position.
And I'm going to have to apologize because right after this, I'm going to have to leave. I've got another meeting. But, I would agree with you that from a media perspective, leading with that has a different impact than when you're in a community setting or a one-on-one setting. And you have the opportunity to have that extended conversation or the additional conversation around, okay, let's acknowledge that and now let's move beyond it. And talk about the other factors, and we try to work with media and do that education, and when a story like that comes out, being able to point out to them that that does more harm than good. Sometimes sometimes you're able to get reporters or their editors to listen to that. Sometimes you're not.
Absolutely. Absolutely. Well, we know that you have to go. So Health Director Frank Thompson, thank you so much for your time and thank you for your service again to the community.
Thank you.
Angela?
Thank you, Dr. Thompson, for attending. We're going to go on to our next question to CEO of Health Forward, Kiana Thomason. So we all struggle with chains of information because there aren't a lot of fact checkers, especially when people are getting their information from social media, from word of mouth. There aren't always people to verify the facts. So we need people we trust to give us adequate information, and also at times with a sense of cultural competency and appropriate language, as mentioned before, that can be tailored to underserved communities. So where do you think we could turn for this in the health industry and providing these kind of cultural, competent, broken down facts for our community?
Sure. I'm going to go back and punctuate the point that Dr. Patton made, and I expounded upon around partnering with community health workers, promotoras, sister doulas or doulas, peer support specialists in the behavioral health and mental health treatment environments, because these are the individuals who know enough about the medical system to help be able to translate language and information in a way that's accessible and understandable, but also live among these communities and carry their trust, have walked in their shoes, and have a story to tell themselves. And I think that those stories and their ability to translate this information or from someone that shares cultural proximity really cannot be understated and undervalued. So I think it's imperative that our health system continue to partner with these roles in the sharing of information. And these people oftentimes are very valuable in that they bring back information and intelligence from the individuals they are serving back into the health systems to help us tailor our practices and plans with respect to engendering trust and how to facilitate that. I'd again expound on amplifying the work of our media partners like Our Health Matters, who does a fantastic job here locally at catering to communities of color and working with different cultural groups. Our Black Greek letter organizations, fraternities and sororities, who are also oftentimes trusted messengers in communities, who are serving day in and day out, year round in our communities, and so many other organizations like the links of many communities across our country, like the Midwesterners and the Boulay, who are serving in Black communities on a daily basis. So just want to highlight the natural infrastructure that we have in Black communities, and there are the same in other communities as well. I do want to go back and really amplify what Dr. Patton said with respect to people being vaccine slow. And this is connected to the question about, are we doing more harm than good or entrenching mistrust by talking about it? Agree with everything that Dr. Olarte and Frank mentioned in that respect. What I'd add to it in terms of being vaccine slow is that thinking about health is a luxury. And all of us who are employed and have employer-sponsored health coverage, we get to think about our health, right? We get to take time off because we're paid for sick leave, or we are salaried and we can just run out of the office and go to the doctor. So we think about health because we can. And everyone does not have that choice and that privilege. And so many of the communities that we serve and partner with to serve at Health Forward are the communities that don't have paid family leave, paid sick time, or are able to take sick time off from work, are having to make ends meet and survive. So I just want to really remind us that we have decisions to make right now as a community. And one of those decisions is around the employer mandate that our President Biden administration has encouraged and is being deliberated right now in Congress regarding that employer mandate for employers greater than 100 to take the vaccines to places of employment. Many of those people who work in these large companies are lower wage workers, to include in certain hospital systems and those that have not implemented the vaccine mandate. And if it's struck down at the federal level, then we have decisions to make as a state around those same questions and opportunities. So I just wanted to really punctuate the point that people are vaccine slow because they're not thinking about necessarily their health as a luxury on a daily basis like we are.
That's very true. With that being said, I think we can transition on to the question about what we previously addressed with employment and other social factors. affecting people's vaccine hesitancy and ability to get the vaccine. So as we know, there are other social obstacles that are increasing vaccine uptake in communities of color. There are structural barriers to access, such as work and family responsibilities, like Dr. Olarte previously mentioned, hard to reach vaccine sites for people without cars or poor access to public transportation. And so has an effective model been developed that can be copied by communities to improve the delivery system should future pandemics arise? Dr. Berkeley-Patton, we'd like to throw this one to you.
Thank you. And you know, just to, I think this question really kind of piggybacks more on what Kiana just discussed, the fact that, you know, access is key. And to address some of these structural barriers, we have to address access. Something as simple as transportation can be the most important decision-making or decision that people have to make. Like, am I going to spend money on an Uber or a taxi, or am I going to get on a public bus to go get vaccinated or to receive other health services versus something else, buying groceries, paying for childcare? And so there are many of these structural barriers that get in the way for not just COVID vaccinations, but for other health services. And so we really need to be able to think about how do we address some of those barriers, some of those social determinants of health. And so as we think about, again, access, how can we rethink where we can provide health services? Do they need to be in a medical office? Can they be in a church? Can they be at a community center? Can we think about community clinic-based care so that, again, access becomes less of an issue? And then also, can we take doctors out of their offices and put them in these clinics and have physicians and pharmacists be more accessible to people so they can ask questions? I know one of the things that have been really, really powerful in some of the work that we've been doing in offering vaccinations in community settings, like barbershops, like we were at the Sunfresh grocery store, is having pharmacists and physicians available. We've had so many people who said, you know, I just have a couple of questions that I need to get answered. And we're able to take them from the table where they're checking in to, here's Dr. So-and-so, talk with them about your questions. And I would say that probably 80 to 90% of the time, people make a decision to get vaccinated after they've had an opportunity to talk with a medical professional. And so having that access, again, becomes just so incredibly important and addresses some of the other cultural barriers that we have, because I truly believe that in bringing physicians and bringing pharmacists and bringing nurses and bringing our students into the community as we address COVID-19, I get comments daily about, oh my gosh, that was such a great experience. I didn't realize all the other issues that people were dealing with, because when I see them in my office, I have a certain amount of time and I've got to get them in and I've got to get them out. I had one pharmacist tell me, you know, I've been to so many of these events that now people come up to me, they recognize me, and I'm able to talk with them about some of their health concerns. You know, again, that's access, but it's also boiling down to access builds relationships. And so, you know, again, I think we just kind of have to get out of our paradigms on how we deliver healthcare and how we address COVID-19 as well, because what we're seeing is this has given us incredible opportunities to screen people for other chronic diseases and to get them into care. It's one thing to offer a pop-up clinic and think just because you offer this clinic, people will come and then go on and you know, seek out other medical services. But what we have found is that if you can structure these events in such a way that you can get people linked into medical care, that you can get people the health screenings that they need and be able to follow up with them. We've been able to get hundreds of people into our dental clinic. I mean, we're talking COVID-19, but we're finding out there are so many people who have not had a dental appointment in years. And we're able to get them into the clinic because we started with COVID-19, but we're using this as an opportunity to get people to think about, get them the resources and get them the linkages that they need to take care of some of their other concerning health issues, and breaking down some of those structural barriers to do so.
Those are very great points, Dr. Berkeley-Patton. And it's awesome that COVID has exposed all of these health disparities and allowed us to make better changes to our healthcare system, especially for underrepresented and underserved communities. So transitioning to the lessons that we've learned locally and how this can affect systemic change, according to last week's data, 56% of Missourians have received at least one dose of the COVID vaccine and 50% have completed vaccination, but only 40% of Kansas Cityans are fully vaccinated. So 50% of Missourians compared to 40% of Kansas Cityans. Kansas reports 55% vaccinated with one dose and 48% fully vaccinated. So do we know what the trends are on what is driving these low population vaccination numbers, and what local lessons could we be learning from this?
Well, I feel like the trends that are driving it are the trends that we really just spoke of with respect to the mistrust, but also those that have systemic barriers due to the conditions that shape their lives and that challenge them with through transportation, through childcare, through no paid leave to be able to go and to access this care. It's great that so many of our providers, including our public health department, our FQHCs, have done a wonderful job, as well as Truman, on taking the vaccinations where communities are naturally gathering, grocery stores, churches, community centers, back to school, backpack giveaways, all those types of places are important. And so at this point, it's really about how we now, from my vantage point, leverage our employer community to be able to help individuals get the vaccines where they work with a higher level of access and convenience.
No, so I'm going to go off script, and probably an unfair question, to ask, but how do each of you feel on the panel about the mandated vaccinations? Do you think that is the way to go, or do you think that's a slippery slope?
Mandated from the employer perspective?
Yeah, from the employer perspective, correct.
So with the Biden administration employer mandate, it is requiring, if it stands, that employers who employ over 100 people, even if they're spread within different facilities, require the vaccination. But with that, the vaccine is not mandated on their employees, because employees still have the opportunity to get an accommodation for religious or medical reasons. And so there's still a pathway for individuals to make an informed decision on whether or not this is something they want and to exercise those accommodations. But
or not to take it, right? Which many have. Yeah.
Which many have, and there are employment consequences without some accommodations, though. But all that said, I do believe that the employer mandate, while some might see it as an overreach, I do not, and believe that that is one of the best methods and pathways for us to reach population immunity and for us to be able to address this issue that is not just causing, of course, harm and death, but also economic peril to our community. And I really liken this to the fact that employers, or large group employers who employ a certain amount of employees, are required to offer health insurance. So no different, required to look at the vaccine, and individuals can make their choices and exercise their accommodations if they choose to.
Dr. Berkeley-Patton, and then Dr. Olarte, any strong thoughts either way?
Yeah, I agree. And yes, it can be a slippery slope, but I am certainly in favor of it. You can't have a healthy workplace if you have people who could potentially spread this virus. And I mean, just as you have to be concerned about the health and safety of your employees, this falls within that wheelhouse. And so I'm all for it.
Okay, thank you so much. Dr. Olarte.
Yeah, I don't have much to add. All I can say is that vaccines save lives, and that has been proven.
Exactly. All right, here's a question. How do you think this conversation around culturally competent care will impact the approach and the success of healthcare in the future?
Well, in my view, there is no such thing as high quality care unless that care is culturally responsive, unless it's equity centered, unless it's trauma informed. So all of those factors are supportive mechanisms to ensure that care is resonant, and you can't have quality without having all those factors. And whether you look at health equity and culturally responsiveness in healthcare as the right thing to do, or whether you look at it as it has an impact on the bottom line and the financial health of an organization, both are true. There is an economic burden and a cost to health inequity. There is an economic burden and cost to racism in healthcare, to bias in healthcare. It causes medical errors, it causes readmissions, it causes people to die. And so we pay for that in some shape, form, or fashion. We all pay for that. And so whether it's the moral good or the mighty dollar, whatever one you want to prioritize and value, it will be the health system's loss not to focus on health equity in a systemic and strategic coordinated way moving forward.
I believe we have answered all of the audience questions thus far. So if you have any more, please put them in the question and answer box and we'll try to get to them. All right, so I'm going to start with Dr. Berkeley Patton and then move from there. 2 questions. Your top frustration about not being able to reach more people to get vaccinated, and 2, if the health community had a do-over on handling the pandemic, what would you change? Whichever one of those you want to tackle.
Well, of course, my biggest frustration is, COVID-19 is largely preventable. At least we can reduce some of the significant negative outcomes that can come from it, like hospitalizations and death. And so if we can just get a simple message out about that, that would be just a huge, huge win. If we had a do-over, I think that while we had tremendous efforts by our health departments, our FQHCs, our hospitals to get vaccines out, I think the miss was in really partnering and having already established an infrastructure through which to partner with community organizations, as opposed to having to quickly just get to whoever you could get to hold vaccination events. I think this is really a time when we should look at what kinds of infrastructures can we build so that when the next pandemic, the next issue, because there will be another one, comes along, we have those communication channels already built. We already know who the influencing leaders are. We already have systems where we can quickly develop appropriate messages. You can't send the same message to every person. Youth need a different message. Older people need a different message. People of different ethnic backgrounds need a different message. And I think just as importantly, we would have our digital divide addressed. We learned so many things during this pandemic. And one of those things was the fact that many people could not register, use the registration systems, access the registration systems for COVID-19 testing and for vaccinations. We learned that a lot of people needed to be able to pick up a phone and make a call and try to register online, and having those type of sources of communication are certainly needed, but we also need to address having enough availability for people to have the internet in their homes, for people to have training and feel confident about their use of online processes to register for whether it's vaccinations, testing, or even other kinds of health services. And this also speaks to the fact that we know that many people don't even access their own electronic health record because they don't have access to the internet or feel uncomfortable in how to use it. And so those would be my things that if we had a do-over, I'd really love for us to be able to address.
Great points. Ms. Thomason and then Dr. Olarte. Same question, frustrations and then a do-over.
Okay. Dr. Berkeley Patton really nailed it.
Yeah, she did.
She did. There's not a whole lot left to be said. I think my frustration has been the political polarization that's been attached to this vaccine. And I don't believe we would be in the situation we are in today with respect to the low numbers of vaccinations if we would have not had this polarized climate attached to it. And so that's been my top frustration. I guess adding to the comprehensive response Dr. Patton has offered would probably be that the health system with a do-over would have focused on building trust within communities before they needed them to do something. That is the wrong time to get people to do something or to get people to want to trust you, is when you're asking them for something. You want to build that trust so that it's there when you need their help and you need them to activate. However, that's wasn't the case. And so the question is now, what do we do? And so we are working to bring the Institute for Healthcare Improvement to town. We are working with the Kansas City Health Collaborative, a membership organization of payers and providers, public health departments, the community health ecosystem, to focus on two things: health equity and anti-racism in our region through learning and action. And so we're looking forward to lifting up shared learning around what health equity is, how to engineer anti-racism as a quality improvement strategy, and how to act together as a community that's all focused on shared goals. And so that is the next step that we are acting on, that's strategic, and that's focused systemically on what do we do now.
Well, Ms. Thomason, you nailed it too. All right, Dr. Olarte.
Yeah, I mean, I echo what Dr. Berkeley Patton and Mrs. Tomlinson said. I share what they said. My top frustration, I think it's been the inequity in vaccine distribution. I mean, I have many frustrations, but that is one of my top frustrations because, just seeing it, like seeing how certain populations did not even have the basic information they needed to access the vaccine, seeing how certain populations immediately had access to the vaccine, and that took several weeks for other communities. And seeing that the specific, the communities of color specifically were the ones in the hospital sick. Just seeing it, that was very frustrating. And that we started with the adult vaccination process, and I don't know if we really learned much from it, but then we're starting the rollout of the pediatric vaccines, and I'm afraid that we're seeing probably the same inequities. And so that is my top frustration. And with the do-over, it would be related to that. I wish we would have started, after we learn with the distribution of the adult vaccines, like what we learned there, like implement that right away also for the pediatric vaccine distribution before we start seeing the inequities and then like question, oh, we should have done it this way. We should have partnered with the communities early on and all that.
Oh, so Doctor, so do you see us repeating the same errors when this is rolled out, or it's being rolled out to the pediatric and to the children as we did to the adults?
I mean, we just started with the, so we started with the 12 and older, and then we just recently started with the 5 and older. So, I mean, it's probably not as pronounced differences as we saw with the adult vaccine, but I hope we don't repeat them. I mean, there is a difference. I don't have numbers to say the magnitude of this, if it's equal or not.
Understood. Angela?
Yeah, so there was a question from the audience, and she had said, I believe that employers should be required to offer paid leave in order to allow folks to receive the vaccine and recover from any side effects. Why do you believe that the frequent tendency of the public health system is to push individuals to take on the burden of change rather than pushing the system to accept the change?
I think we've been very much conditioned as a health and social sector to focus on people fixing and not system fixing and systemic repair of the conditions that shape the world and environments that people live in. I'm not convinced that the mandate from the Biden administration doesn't require employers to offer that. I really can't speak on that. I would not be surprised if that's attached to that mandate, but of course that's just for employers with 100 employees or more. But I think it's a very valid and apt question that should be addressed.
Anyone else want to weigh in on that one? All right, hearing none, we do have a closing question. We're doing great on our time, and this is for the entire panel. We discussed this trust factor when we began this discussion, but this question is probably best asked in closing. So the public trust in government is arguably at an all-time low. The tearing down of fundamental institutions that allegedly help make America what it is also at an all-time high. Are we prepared, and are you optimistic about our ability to combat future health challenges regardless of what form that takes? But let's just say for another pandemic, let's say we get past this, 5 years goes by. Are we prepared, not only as a nation, but also as a medical community, to do better and to be able to not have it impact us as much as it has? I'm not going to pick on anybody in particular to start. I'll let the panel decide.
I think we're all accountable. I'm sorry, Dr. Olarte, go ahead.
No, I was just going to say, we cannot have another pandemic. We had enough. But I am optimistic. And I'm realistic at the same time that, change is not going to happen overnight. It's going to take a lot of effort from all of us. And by all of us, I mean all human beings, not just communities of color, fixing this problem. It's probably going to take decades. But I am optimistic that with right now we are currently, speaking from the medicine and science world, we're seeing this, in the high peak of interest in diversity, equity, and inclusion topics and discussions. I hope this is not just like a peak that is gonna, the interest is gonna slow down and disappear eventually. I hope it continues like that we've learned our lessons and realize, what we've done wrong in the past and how this has impacted many communities. But so I'm optimistic because in the past year or so, I've seen change. It may not be, some people may say, oh, it's just, symbolic because of what we are living, like the pandemic that has magnified all the health inequities that have existed for so long. But at least in academics, in our academic and professional societies and medicine, there's a lot of discussion about how we've been doing some things wrong, how we've been using race and ethnicity in research as a variable without putting too much thought into it, and then analyzing results and assigning like a role to race, ethnicity when the study was not designed to do so. And as a result, we had like even guidelines where things like a lower risk of urinary tract infections in pediatric patients that identify as Black patients was stated in a guideline. That guideline was recently removed by the American Academy of Pediatrics because that was not a study done to support that statement. So, examples like that we've seen recently, also in medicine, especially in infectious diseases. Recently, we saw the change in nomenclature. There's vancomycin is an antibiotic that we use. It has a very known reaction that is related to how fast it's infused into the patient. And the reaction is just the patient gets really flashed. So, red face, red neck. And this condition was known for many decades in medicine, and we use it all the time as red man syndrome. The Native American community has been asking for many, many years to change that because that was a racial slur. Nothing happened for many years. But since we have this, new interest in DEI topics, that was brought up again. And after, not too many discussions, it was changed. And now we just call it vancomycin flashing syndrome. And so something that took so many years without seeing any change, now with this new interest, we're seeing that some things are changing. Of course, this is such a small, tiny baby step into fixing all the wrongdoings, but it's just one step forward. And these are just examples of little things that we're seeing, and also like how we should be using race and ethnicity in medicine, because many times we use that not in the right way.
Thank you, Dr. Ms. Thomason, and then Dr. Berkeley-Patton.
Are we prepared? Am I optimistic? I am hopeful. I'm very hopeful, but we know hope is not a strategy, right? So we have to prepare and plan. Some of the things that we must do to prepare for the next pandemic and to emerge out of this one differently and more equity-centered is we have to invest in our public health infrastructure. Missouri and Kansas are woefully under-resourced with respect to public health per capita spending. Missouri ranks 41st, Kansas is 40th, and I might have those two transposed. But we got to fix that. We have to fix that. So the federal government's share in public health spending has been dwindling for the past 30 years. We've got to resource that as a city and as a state. And so we need to be mindful of that as we interact with our legislators. We have to focus on race, ethnicity, and language data so that we know the full story of what really happened in COVID with people of color and what is happening on a daily basis with respect to health injustices. I don't say health disparities because it's not fitting for what's really happening. But the daily occurrences of health injustices within our healthcare system, within our public health system, we need that data to be tracked and shared and measured so that we know what we're swinging at. We need to reimburse for community health workers within Medicaid plans, within employer-sponsored insurance plans, and we need to ensure that our workforce looks like the individuals we serve, to include governance, the boards and the commissioners of our health systems, public health departments. We need to ensure that there is people of color in positions of decision-making and leadership, and of course, in clinical roles and data and analytic roles. And so we need to have equal attention on that. So that's just a few things that we need to focus on to be prepared for the next pandemic.
Dr. Berkeley-Patton.
I'm hopeful, slightly, because there's so many entrenched systemic things that need to change until everyone has the same luxury that we do, the same privilege that we do to be able to make their health a priority, as opposed to secondary to daily life hassles like taking off from work, not having transportation, not having childcare. not having money for co-pays, not having times of availability of health services that they can access that make sense for their schedules. Until those systematic changes take place, I'm slightly hopeful. I'm also slightly hopeful because we do see where there are growing opportunities, emerging opportunities to get more people of color in pipelines for health professional positions. We know that we need more people of color as doctors, as psychologists, as health policy makers, as CEOs of companies that make these policies and decisions that impact people's daily lives and therefore impact their health. And then lastly, I think we need to have new payer systems, not only for community health workers, but new payer systems for how do we pay the community partners that we so direly needed in this pandemic for the work that they're doing to help encourage and motivate people to get vaccinated and to get back into healthcare. We have to think about them as equitable partners. We have to think about their time and their effort and not always lean on our community organizations as volunteerism type work. And so we need to think out of the box in how we include them in our payer system as well, because the work that they're doing in this pandemic is so important and so valuable. They need to be able to get paid for that as well.
Each of you, very well said. To our esteemed panel, thank you for sharing not only your knowledge, but also your time. And it just can't be said enough. Your service to the community is appreciated, and we are grateful for your competence and your dedication for keeping us healthy. Dr. Berkeley Patton, professor at UMKC, Biomedical Health Informatics. Dr. Olarte, Division of Infectious Diseases at Children's Mercy, Kansas City. Ms. Thomason, CEO of Health Forward, thank you so much. And Kansas City, Missouri Health Director, Frank Thompson. And also to my co-moderator, Ms. Angela Wankwu. As we close, I want to thank UMKC Chancellor Mali Agrawal for his commitment to these discussions that benefit the UMKC community and the Kansas City community as well. To Dr. McKinney King, Interim Vice Chancellor of the UMKC Division of Diversity and Inclusion, Executive Assistant Yvonne Hood, who keeps us on track, keeps me on track. I'd be completely and utterly lost without her keeping me up to date as we plan these events. And the same thanks goes to Lana Davenport. And last, but in no way least, Mr. Highview, who provides us and the university with online system support. No one does it better. And thank you for joining us as the participants in this critical conversation. Until next time and beyond, please stay well and stay safe.